Okay, let's go ahead and get started. My name is Cindy Harmon. I'm with DHHS Health and Human Services in Nebraska. And you are joining the session with Alison Keyser-Metobo. And the session title is Using and Collecting Social Determinants of Health and Demographic Data to Better Serve Your Community and Improve the Knowledge of Health Outcomes for Nebraskans. Our speaker is Alison Keyser-Metobo, and she is a epidemiology surveillance coordinator with the state of Nebraska in the Department of Health and Human Services. Please welcome Alison. Alison, we're going to turn it over to you.
Okay, thank you, Cindy. So, like Cindy said, I am going to talk about the importance of collecting social determinants of health and demographic information. Health equity is the basic principle that all people have a right to health. Differences in the incidence and prevalence of health conditions and health status affect groups differently based on socioeconomic status, race, ethnicity, sexual orientation, gender, disability status, geographic location, or some combination of these. And people in some groups can not only experience worse health outcomes, but also tend to have less access to the conditions that support health, such as healthy food, good housing, good education, safe neighborhoods, freedom from discrimination. And data can shed light on health inequities and the major drivers of those inequities and help organizations and communities work toward eliminating those health differences. Data helps communities and stakeholders identify how to understand Data helps communities and stakeholders identify how health varies between different groups. And it's important to understand the magnitude of a health difference and which populations are disproportionately impacted. And health differences that groups in your community are experiencing may be different than at the state or national level. And collecting and analyzing social determinants of health and demographic data can help identify the underlying social and economic conditions, systems, and policies that impact health and are contributing to health inequities. And policies can influence health by impacting access to health services, health insurance, and prevention programs. And policies can also have an impact on social or economic outcomes such as income, education, and employment and housing, which can also influence health. And as organizations and communities address health inequities, it's important to evaluate the interventions that are developed because ultimately we want to use data to ensure that the needs of communities are being met and health differences are being addressed. So I'm going to talk about social determinants of health and demographic data. And addressing the social determinants of health is one approach to achieve health equity. Social determinants of health are the conditions in the environment that people live, learn, work, and play in. And these can include the economic, social, physical, healthcare, and education environments of a place. And I'm not going to talk a lot about the social determinants of health, but there are other speakers at the conference that will go much more in depth into the social determinants of health. So I definitely encourage you to attend their presentations. And demographic data describes characteristics of a population like geography, race, ethnicity, gender, disability status, preferred language, and age. And this information helps organizations and stakeholders better understand the populations they serve and helps communities address morbidity and mortality. And why collect social determinants of health and demographic data? Social determinants of health and demographic data can be used to describe the health status of the community that you serve. Data can be used to help prioritize and target prevention and education efforts. Services can be given in a culturally responsive way, and barriers to accessing healthcare or other services can be identified. And social determinants of health and demographic data helps local health departments and communities respond to outbreaks in a more timely manner. And this data can assist in identifying clusters and outbreaks. And a person's overlapping identities can impact their life experiences and health outcomes. Data is an important source of information about the health status of a population. Indicators about the health status of a population can provide information about the type and magnitude of health inequities being experienced by a population and identify those who are disproportionately impacted. Health indicators can also be used to monitor progress and determine whether interventions are having the desired effect. Some useful disease indicators might include the rate of heart disease, the rate of cancer, the number of people with up-to-date pertussis vaccination, and quality of life indicators are also an important aspect of population health. And quality of life indicators might include life expectancy, mental well-being, employment, and sense of social belonging. And it's important to note that health indicators are not the full story of a community, but can be a starting point for addressing community needs. And communities who address health status are better able to respond to and recover from emergencies. Children are better able to learn. Adults are better able to work. And people are better able to manage chronic diseases. Collecting data on social determinants of health and demographics helps organizations, stakeholders, and communities identify populations that are at higher risk of experiencing poor health outcomes. And populations that are disproportionately impacted by health inequities can be targeted for education and prevention efforts. And data can also help us understand the underlying factors that are driving a health difference, such as the unequal distribution of power and resources across population groups. And the knowledge that data can give an organization provides opportunities to partner with the community and other stakeholders to develop prevention strategies and establish priorities toward addressing health inequities. And collecting data by age, race, ethnicity, gender, ability, and geography make it possible to allocate resources equitably for all community members. And it's also important to monitor the effectiveness of your efforts and interventions. So are your efforts helping people achieve the best health outcomes possible? Are the outcomes of your efforts equitable? And are you collecting data to help you answer those questions? And here are 3 examples of groups that use data to target populations experiencing health inequities. A community food assessment conducted by the Fresno Metro Ministry in Fresno, California, demonstrated that community members shopped for produce at a flea market. And this flea market really served as the main shopping destination for many local individuals and families. But when California switched to electronic benefits transfer cards for food stamps, individuals and families couldn't use their food stamps at the flea market anymore because merchants didn't have the necessary machinery or phone lines to process transactions using EBT cards. So the Fresno Metro Ministry worked with the California Department of Social Services, the U.S. Department of Agriculture, and the California Nutrition Network to try and change that. And now flea market shoppers can use a single wireless electronic device to deduct an amount from their EBT cards in exchange for tokens that they then can take to shop at food vendors. Data collected in Los Angeles County showed that low-income and communities of color had fewer parks and fewer opportunities for physical activity than more wealthy and white neighborhoods. So a diverse group of organizations came together to build more parks in neighborhoods that needed them the most. And so they lobbied political leaders, they organized underrepresented communities, and they also conducted research. And the efforts of these organizations and communities help get 5 local and statewide bond measures passed, raising $15.5 billion for parks, open spaces, and water supply projects. And data showed that children living in Harlem have a higher asthma rate than children living in other neighborhoods. So to combat high asthma rates, the Harlem Children's Zone partnered with the Harlem Hospital's Pediatric Department, Columbia's Mailman School of Public Health, and the New York City Department of Health to launch an asthma initiative. And workers go to families' homes and survey those families to identify children with asthma. And then children with asthma are offered a variety of medical, environmental, and social interventions. And then every enrolled family is followed up at 3-month intervals to determine the effectiveness of their interventions. So culturally responsive services. So who is already walking through your door and receiving your services? Who isn't receiving your services? Data on the community you serve can help you understand how different groups in your community experience and access your organization's services. And this information can help organizations better meet the needs of the community. And organizations that design and implement services that incorporate the knowledge and the unique cultural experiences of the community they serve are able to respond respectfully and effectively to their clients. And the staff at those organizations will better reflect the makeup of the community they serve. And developing culturally responsive services is important because we know that different populations experience the healthcare system differently. Ethnic and racial minorities are less likely to have a regular doctor or health insurance compared to white non-Hispanics. And people that don't have a regular doctor are less likely to get preventative services, manage chronic diseases effectively, and get treatment. And language barriers can lead to lower quality and amount of care received, as well as the ability to understand and retain important messages about treatment or prevention. So providing culturally responsive care helps people achieve the best health outcomes possible and can work toward reducing health disparities. And implementing class standards is one way for an organization to increase its capacity to provide culturally responsive services. And the class The purpose of the class standards is to advance health equity, improve quality of services, and eliminate health disparities. And the class standards are made up of 15 action steps in 4 broad areas: principle, standard, governance, leadership and workforce, communication and language assistance, engagement, continuous improvement, and accountability. And if you would like to learn more information about implementing class standards, I encourage you to go onto the Nebraska Department of Health and Human Services Office of Health Disparities and Health Equity website. They have great resources there, and they also provide technical assistance. And Health and Human Services also has a website. And it's important for communities, stakeholders, and organizations to understand what differences exist between different populations in their ability to access healthcare and what barriers exist. What experiences do people have accessing the services your organization provides? Differences in access to healthcare across different populations contributes to health inequities and can lead to worse health outcomes for those that have a harder time accessing care. And barriers that people might experience could include lack of health insurance, lack of financial resources, irregular source of care, lack of healthcare providers, language barriers, and transportation barriers. Addressing barriers to accessing healthcare can help people better manage chronic diseases, get needed medication and treatment, live longer, and have a medical home. And information about healthcare access can come from national surveys, or an organization can develop their own data collection tool to get information on the population that they serve. Getting geographic location information such as address can help us respond to outbreaks in a timely manner. There are about 90 infectious diseases that are reportable to the Nebraska Department of Health and Human Services, and the vast majority are diagnosed by a lab test. So if you go to the doctor and your doctor orders a lab test and it comes back positive for a reportable disease, we will get that lab result, and then we can interview you and get some more information from you. And when we get a lab report, we use the demographic information to get the lab result to the right local health department for follow-up. And if we don't get address, it can take a lot of time to contact the clinic or the lab that did the test to try to find out where the patient lives so we can get the lab report to the right local health department. And geographic location information can also help us identify outbreaks that impact more than one local health department or state. And address information was critical in helping us respond in a timely manner to a Campylobacter outbreak in City A. Campylobacteriosis is a diarrheal disease caused by a bacteria that contaminates food and water. So the state health department and the local health department got reports of a higher than expected number of Campylobacter cases in City A. And as the local health department was investigating, they learned that City A's water supply comes from 4 untreated wells. And the city used water from the various wells on a rotation. So all the wells were not online at the same time. But when a well was online, it provided water to the whole town. And the health department also learned that recently a center pivot malfunction allowed livestock wastewater to collect in a ditch near two wells that supplies City A with water, instead of flowing into an adjacent farmland. And this resulted in contaminated well water. So having address on positive Campylobacter labs helped us link ill people in a single jurisdiction to a single town, City A. And address also helped us establish where the ill people were, and we were able to show that cases were not clustered in one area of the town, which indicated a widespread issue with the water system. So as a result of the investigation, 2 wells were removed from service, and we did not get any additional illnesses. And data about where a person lives, works, and plays helps us identify clusters and outbreaks. Occupation has played an important role in COVID-19 risk. So collecting occupation information from COVID-19 cases is important because certain occupations are more at risk for COVID-19 infection because of the nature of their work, such as healthcare workers, first responders, meatpacking workers, and teachers. And collecting age and address can help us better prevent and respond to meningitis cases. College students have a slightly higher risk of meningococcal disease than other teens and young adults because of congregate living. And address and age information can also help us identify children living in zip codes that have older housing, which can put them at an increased risk for elevated lead levels. So it makes it much more difficult to identify and respond to clusters and outbreaks when we don't have information about the social determinants of health. And as you look at data through a health equity lens, it's important to consider intersectionality when collecting and analyzing data. Intersectionality is a concept introduced by Kimberly Crenshaw, and it is an approach to understand the multiple forces that shape social inequalities and discrimination. Individuals have overlapping identities when talking about social categorizations like race, class, sexual orientation, ability, and gender. An individual is not a man on one hand and a person with a disability on the other. He is both of those identities at the same time. And these multiple identities create overlapping systems of oppression and privilege, which impacts an individual's lived experiences, including how easily they access healthcare, how they experience the healthcare system, and how easily they're able to respond to and recover from emergencies. So it's important to consider how you can capture a person's multiple identities when you collect data. And to ensure equity in your data analysis, it's critical that you use data to reflect the fact that a person's experiences are based on multiple dimensions or identities. So we've kind of talked about the why of collecting social determinants of health and demographic data. Now the how. The Nebraska Department of Health and Human Services developed a data recommendations report that provides recommendations for the collection of 6 demographic indicators. And these 6 factors represent a minimum data set that can be used to identify and describe health inequities in a population. So those 6 factors are race and ethnicity, primary language, gender, age, disability, and geographic location. So for race and ethnicity, ideally that is self-reported and is asked as 2 separate questions. Primary language is a measure of English proficiency rather than language spoken. And gender should be self-reported whenever possible. And for age, we would like to collect birth date rather than like an age group or a numeric age number. And disability focuses on the impact certain conditions may have on that individual's basic functioning. And for geographic location, ideally you would collect complete address. So that would include street address, city, zip, county, state. And so there are different data sources for demographic and social determinants of health data. Surveys are a good source of information. The U.S. Census and the American Community Survey provide demographic and household information. There are also examples of national surveys such as the behavioral risk factor surveillance system, which asks adults about their health status and health behaviors. And a clinic or organization can also design their own survey to get information about the people they serve. And lab test results and investigations are another source of demographic information that help us identify and stop outbreaks. Workers' compensation data can help tell us about the population of workers that get injured on the job. And key informant interviews can provide data and insight about a community's experiences that other types of data can't. Focus groups can provide information about met and unmet community needs. And there are 2 commonly used types of data, primary and secondary data. Primary data is information your clinic or organization collects. So this can include surveys or intake forms. Primary data is specific to the needs of the community and stakeholders. You have full control over how the data is collected. You determine what questions are asked. You determine how those questions are asked. Primary data also tends to be more timely than secondary data. But the disadvantage of primary data is that it is expensive and time-consuming to collect. So secondary data is data that is collected by someone else. So CDC Wonder and the census are examples of secondary data. When you use secondary data, it's important to become familiar with the data set. So how was the data collected? What populations was the data collected from? What was the objective and purpose of collecting the data? How complete is the data? Secondary data is generally easily accessible. So you can go onto the CDC Wonder or Census website and download data for your state, county, or census tract. Compared to primary data, secondary data is lower cost. It doesn't require a lot of time, and is usually collected on larger sample sizes. The limitations of secondary data include the data not being specific to the needs of the community or stakeholders. So it may not exactly answer the questions that you want. And you don't have any control over the data quality. And secondary data is generally not as timely as primary data. Okay, so I want to have you guys answer some discussion questions. So I want you to think about, does your organization currently collect or use primary or secondary data? And if so, what data sources are you currently using? So go ahead and put your answers in the chat or ask or raise your hand to speak.
Sarah? Sarah Pate? Okay, Sarah Pate asked to speak, but her microphone isn't working. So does anybody else have something they'd like to add? There's a comment from Sharon Obasi. Yes, my organization uses both primary and secondary data. And Sarah Pate added, we use data sets to help with grant writing.
Okay. So now, what types of data is your organization collecting? So what types of information are you collecting?
Person number 51129 says they collect demographic data in EMR and Invocator. And Sarah said they collect secondary data.
Okay. So what kind of secondary data sources are you using?
Sharon responded, they're collecting demographic information. Person 51129 added, electronic medical record and Invocator is our care management documentation system which tracks social determinants of health.
Oh, nice.
And Sophia said BRFSS. Sharon added, secondary data sources are American Community Survey, and the census, etc.
Nice. Okay.
Mary added, we collect demographic, compare census to our demographic data.
Hmm. So it sounds like a lot of you are using demographic data, both primary data sources and secondary data sources. So how is your organization using data? I heard grant writing earlier as one way that data is being used. Are there other ways that you guys are using that data from the American Community Survey or from your health records?
Sharon responded with grant writing and research. Melissa added, within our department, we use national and local data sources such as SEER, NCDB, NSQIP, NBR, QIP, EHR data. Our team uses it for comparative effectiveness and surgical outcome research. Monica said they use information to inform training for our clinicians. And 51129 added, we concentrate resources and place physical staff in demographic locations that have the highest social determinants of health barriers.
Great. It seems like data is being used in a lot of different ways to benefit the communities that you guys are in and the clients that you serve. So before you start collecting and analyzing data, it's important that you develop a data analysis plan. And a data analysis plan is really a roadmap for how you're going to collect, organize, and analyze your data. Once you start collecting data, it's really difficult to go back and add or change things. So it's important to be clear about the purpose of the analysis. So what questions are you hoping to answer? Who is your target population? And who will be included in your analysis? And your goals and purpose will help you determine what information you need and how you will collect it. And the next step is to kind of figure out what data sources you are going to use. So are you going to develop your own data collection tool, or are you going to use available secondary data? And what are the potential limitations of the data that you are going to use? You want to map out and define what variables information you're going to collect, and develop a data dictionary so everyone is clear about what each variable means. So a data dictionary should define the content and structure of the data. For example, the variable or data element lab results could describe the result of that individual's COVID-19 test, and it could be positive or negative. And you want to determine what your target population is. Are you going to have, what population are you going to target? Are you going to have a comparison group? And how many people are you going to need to get enough statistical power for your data analysis? And it's important to determine what type of statistical analysis you're going to do before you start collecting data. And this includes making a plan for how you're going to deal with missing data as well as outliers. And what descriptive statistics are you going to calculate? And are you going to make comparisons between two groups? If so, what statistical methods are you going to use to compare those groups? And it's also helpful to put together dummy or empty tables and figures because that can kind of help you visualize your data analysis plan. And as you're putting together your data analysis plan and mapping out what your evaluation questions are, it's important to try to think beyond asking questions about behavior. Questions about behavior are important, but they don't get at the underlying physical, social, and economic conditions that contribute to health inequities. Questions about behavior also don't help organizations or communities understand the barriers people face in achieving the best health outcomes possible. So some examples of questions that look at behavior are, what is the overall diabetes rate in a community? What groups have higher rates of diabetes than others? What behaviors contribute to the reduced risk of diabetes? And what health risk behaviors are more prevalent in one group compared to another? And here are some examples of questions that try to get at the structural conditions that influence health. So asking what living and working conditions contribute to the risk of diabetes? How are the living and working conditions different in groups with higher rates of diabetes than others? And what structures, systems, and policies contribute to the difference in living and working conditions of different groups? So you'll find as you are kind of laying out your data analysis plan that there are barriers to collecting social determinants of health and demographic data. Lack of standardization of race, ethnicity, language, categories is one example. So if different collection forms ask for demographic information in different ways, it makes making comparisons impossible and can result in low quality data. And if you don't understand why data is being collected, it's difficult to develop a data collection and analysis plan, and that can lead to data not being analyzed or used. And informatics limitations can make it more difficult to collect social determinants of health and demographic data. So do different systems talk to each other? How timely is the information being reported? What is still being reported on paper versus electronically? Does a person's demographic information automatically populate fields in the system? And is demographic and social determinants of health information stored in a different part of the system from other information about that individual? And if there isn't space on a collection form to get demographic or social determinants of health data, it's not going to be collected. And individuals may not feel comfortable disclosing information if they don't understand who will see the data, how the data is protected and how it will be used. And sometimes provided categories on a form are not sufficiently descriptive for local populations to self-identify. So the information collected may not really accurately describe the population. And there may also be discomfort asking or answering demographic and social determinants of health questions, which can impact data quality and completeness. Okay, so I have some more discussion questions. So what are the greatest capacity-related barriers your organization faces when collecting and analyzing data?
As a reminder, you can enter your information in the chat box or raise your hand under the participants menu and we will unmute you. Okay, there's a comment from Molly who says, our biggest barrier is time and resources, as data collection and analysis is an extra duty that we do as nurse practitioners.
That is definitely a very common barrier for organizations.
Jessica Gutierrez mentioned language is also a barrier. Person 51129 added, our greatest barrier is learning how to develop the right platform to collect and analyze the data, as well as the time and resources to collect the information.
Yes, definitely collecting and analyzing data takes time and resources and a plan for how to do that. So the next question, so just focusing on primary data, for those of you that use primary data, what are your greatest barriers that you face collecting and analyzing primary data?
Jean Fisher just added, also the burden it can place on participants to collect primary data source information.
Mm-hmm. Okay, so now focusing on those of you who use secondary data, what are the greatest barriers your organization faces when collecting and analyzing secondary data sources? Mm. Yeah, I see the comment, the burden it can place on participants to collect primary data source information. Yep. So do people feel pretty comfortable about knowing where to access secondary data and how to get it, and kind of understanding what the data source is and where it comes from?
Elizabeth adds, would love your perspective on all of those questions you just posed.
Yeah, I have. Yeah, learning about secondary data is definitely a process. I happen to learn about secondary data sources mostly from other epidemiologists or conferences that I go to. There is a speaker at this conference that is going to be talking about data sources. So I have not found a really good kind of one-stop shop for secondary data sources. And I have also found that some websites explain their data better than others. Some websites do a really good job talking about their methods, talking about how they collect the data. They may even have the collection tool on their website. Like the BRFS survey, you can go on the website and download the survey for the year. So you know exactly what questions are being asked. And a good website will also talk about the limitations of their data as well. So that's my perspective. I definitely don't think it's easy to find or access secondary data. Sometimes you just kind of find out about it by accident. Okay, so for the sake of time, I'm going to move on here. So 2 ways to overcome data collection and analysis barriers is to get high quality data and regularly evaluate your data quality. High quality data and effective data quality assessment are really required for accurately evaluating the impact of public health interventions and measuring public health outcomes. Data standardization is the process of bringing data into a common format that allows for data analysis and sharing of data. Data can vary greatly between one organization to the next. So if an indicator like birth date is collected several different ways, it makes comparison between data sets or over time impossible. And data should be collected in the same format. So for example, birth dates should all be collected using month, day, year. And before you start collecting data, you should try and find out if there are already recommended standards for how to collect an indicator and then use those. And it's important to train staff on data collection and data entry to make sure that staff all collects and enters the data the same way. Data analysis becomes really difficult if some staff are only collecting city and state, while other staff are collecting street address, city, zip, state, county. Another important way to improve data quality is to capture didn't ask versus missing versus prefer not to answer. These all mean different things, and differentiating between those three can help you improve the quality and completeness of your data. And we talked a little bit about how if you're using secondary data, you definitely want to try and understand your data source. So evaluating data can tell you if your statistical analysis are relevant and representative. So in other words, is your data serving its intended purpose? So I'm going to briefly talk about 5 measures of data quality. Completeness is a measure of to what extent required information is present in the data. Missing information can reduce your statistical power and introduce bias. And it's important to regularly look at the completeness of the data you're collecting and strategize how to improve your completeness. Representativeness is a measure of how well the people you are collecting data from represent the population at large. So the conclusions you draw from your analysis may not be accurate if the people who you are collecting data from are older or more male or more urban than the population that you are targeting. Timeliness relates to whether or not the information is up to date for its intended purpose. If you analyze data that is old, your conclusions may no longer be relevant. And reliability measures whether or not your questions provide accurate and meaningful data. So how consistently does a question measure something? Validity evaluates if the data you're collecting measures what it is supposed to measure. So there are multiple underlying causes of health inequities, and public health and the healthcare system alone can't address such inequities. So important fields to partner with might include education, economic development, transportation, housing, advocacy organizations, and businesses. And partnerships between multiple fields and sectors can work to improve the underlying conditions that can give people the best chance to have the best health outcomes possible. And organizations that work with populations experiencing health inequities are important partners to have. These organizations have knowledge about the norms, culture, and needs of the communities they serve. And as you develop relationships and perform partnerships, it's important to develop a mechanism to ensure new voices and perspectives are heard. So periodically assess who is part of the group and what new members should be invited to participate. Also be mindful to try and make sure that meeting times and locations are as convenient as possible for everyone. And while it's important to have a diverse group of partners, don't assume that individuals from a specific group can speak on behalf of all members of that group. And all partners should have equal opportunities to contribute to strategy development, implementing solutions, and making decisions. And it's important to recognize that some partners may need additional resources in order to participate because of staff or organizational resource limitations. And before you engage or partner with the community, take the time to develop relationships and trust. Work with formal and informal leadership. Take time to listen to the community. This can uncover key community concerns, build understanding, and generate new ideas. And also recognize the different kinds of groups that are part of the community. This can include farmers market vendors, soccer leagues, student councils, or informal groups that meet at coffee shops. Be transparent with the community about your goals and expectations. Be honest about the purpose of your project and how you will use the community's input. And always follow through on your commitments. Understand historical context. Be transparent. What are the stories of success, lessons learned, and barriers that were experienced from previous attempts at engagement? Listen and understand barriers that may prevent a community's participation, and try to come up with strategies to address these barriers. Support community-led solutions. So understand each partner's individual and community interests. Allocate resources so community members can participate. So this might include offering stipends, food, childcare, or interpreters. And make sure that community members can influence decisions that impact their community. And also recognize how participants' contribution has made a difference. And so when communities are engaged in the process of collecting and analyzing data, there's an increased awareness of health inequities and social determinants of health and how they impact health outcomes. The data collection and analysis is more likely to be relevant to the community when they have a voice in developing the data collection and analysis plan. And the community also develops a sense of ownership of the data analysis results, and it creates opportunities for partnership and can lead to the development of equitable programs, practices, and policies. So I'm going to show you an example of a Healthy Communities brochure that was developed by the Department of Health and Human Services Maternal and Child Health Program. That it looks at concentrated disadvantage and teen birth. So this is kind of an example of taking data to action. So the first page lays out the importance of going beyond looking at individual behavior and talks about how neighborhood conditions can impact health. And the second page defines concentrated disadvantage, which is an indicator of the relative well-being of a geographic area. We mapped concentrated disadvantage by census tract, so you can see the level of concentrated disadvantage experienced by different census tracts. And this page also lays out the benefits of addressing concentrated disadvantage. And the third page uses data to show the relationship between concentrated disadvantage and teen birth, and also talks about the importance of forming partnerships to help address concentrated disadvantage. And the last page is a call to action and the next steps for organizations and stakeholders. So data can be used to tell a story, which helps communicate key insights in a clear and compelling way that can inspire change or action. So as you're thinking about sharing your data analysis results, first determine what the goals are. Are you hoping to build on current knowledge? Are you helping people understand a new problem? Are you hoping to get funding and support? The Healthy Communities brochure had several goals. So can an outreach piece about concentrated disadvantage and teen birth help communities understand how neighborhoods impact an individual's health? Can it help communities understand how concentrated disadvantage impacts outcomes such as teen birth? And can creating an outreach piece encourage partnership building and go beyond focusing on individual behavior? And one of the most important aspects of sharing data findings is understanding who your audience is. How is your data relevant to your audience? Does it solve a problem they care about? What do they already know about the subject you're speaking about? And the characteristics of your audience will help determine how to tailor your message and make it compelling and accessible. And it's important to consider how the data results are being shared with leadership and decision makers, and to ask if the data results are being shared with the populations experiencing health inequities. So the audience of the Healthy Communities brochures was organizations such as community action agencies, federally qualified health centers, and local health departments. So your goals and audience will help you determine the best way to visually present the data. The way you visually present your data can have an impact on how your audience understands and receives the message you're trying to convey. So keep your data visualization simple. Always choose the simplest way to visualize the data. Don't use a chart with too much text, too many numbers, or too many colors. You want to have a specific message that you want to communicate. So identify the relationships and patterns in your data and focus on what you want to show. What does your audience need to know? What is important to them? What questions might they want answered? And tailoring your message and considering your audience increases the chance that your data visualization will result in actionable insights. And you want to select the right chart for your data. Selecting the wrong type of chart can kind of distract from your data story. So bar charts can be used to compare data across categories. Line graphs reveal data trends over time. Pie charts show relative proportions. And tables can be used to organize detailed or complicated data. You want to keep it simple, but you can use color to highlight or emphasize what's important. So color can be used to highlight the data that the viewer should pay attention to. Color can also be used to highlight outliers and anomalies if your goal is to point those things out. So once you figure out the best way to visualize your data, you want to figure out how you're going to share that information. What format is the best way to reach your target audience? Are you going to conduct town halls? Are you going to put information in newspapers and on the radio? Are you going to put information on the internet or social media? The findings of the Healthy Community brochure was shared in several different ways. Forums were held with members of the target audience to get feedback on the brochures. We helped organizations strategize a list of existing and new potential partners and how to begin to reach out and form relationships. Organizations in areas that are experiencing high levels of concentrated disadvantage were spoken to like on an individual basis. The brochure was put on various websites and data was presented at conferences. So to summarize, collecting the social determinants of health and demographic data is one way to advance health equity. Data can help shed light on health inequities experienced by the population and the underlying drivers of those inequities. There can be a number of barriers to collecting the social determinants of health and demographic information. It's important to understand those barriers and strategize ways to overcome them. And one way to address those barriers is to get high quality data and regularly evaluate your data quality. And good quality data can give you a complete, accurate, and timely information, which is essential for decision making. And health inequities can't be addressed by public health or the healthcare system alone. So an important part of advancing health equity is engaging partners and the community in the data collection and analysis efforts. And sharing data can help improve public health and foster partnerships in innovative solutions. And I put a couple slides in here that just have some helpful websites for you. So I am done.